We have a couple of questions so far in the chat that I would like to get your input on, and then I have a few questions that we may also discuss. The first thing, and Betty, you may comment on this, and others too. This is from Dr. Applebaum, but it's one that we had talked a little bit about. So we've compared the late effects in survivors to the general population, but can you comment on comparing late effects in transplant survivors potentially to the late effects in patients with similar diseases who didn't have a transplant? And maybe, Betty, you can give a little overview of that for malignant disease. And Stella, you might want to comment for particularly pediatrics and non-malignant disease.
Thanks. This is a great question, and I think we sort of touched on it a little bit in the first session, in the sense that what it sort of goes back to that question of what happens if you don't get a transplant, or why would you want the transplant? And so, particularly for malignant diseases, this can be a little bit challenging because those malignant diseases are life-threatening and certainly can shorten a patient's lifespan by quite a bit. I know there are studies, and Stella perhaps can add more to this, in non-malignant diseases. In terms of studying this, it does require good databases to follow patients' chronic conditions and late effects with and without transplant. So some non-malignant diseases, I know that we have started to look at this in our CIBMTR databases to try to compare it to other databases as well. But this is something challenging in a malignant disorder.
And I'll just add that there is a study published 3 to 4 years ago that includes colleagues from the Hutch, actually looking at transplant survivors compared to cancer survivors. And at least they're documenting that there's greater rates of hospitalization and all-cause mortality when looking at them as a cohort. Maybe looking at individual diseases might be a little more challenging in having sufficient numbers, but I think there are data suggesting that there are additional comorbidities and additional complications in transplant patients that exceed those who have had more conventional treatment for their cancer. I'll move to the next question from the audience. And Betty, I think you can chime in here, and then I think we'll get others' input. So this question is that for graft versus host disease, how often do we see patients with moderate or severe disease that actually improves until it's resolved or causes only mild symptoms? And are there factors that are well associated with this improvement? And do we know of any kind of biomarkers or other markers or comorbidities that are associated with the severity and occurrence? That's a long question, but it's really in a couple of parts. One is, what are the best predictors? And the second is, can we predict who's going to improve and may experience less long-term disability?
Yeah, those are great questions. So we didn't talk too much about treatment of chronic graft versus host disease, which although excitingly, there are some new treatments, and there's now 3 treatments that are FDA approved for chronic graft versus host disease. But it should be noted that these are approved in the setting of what we call steroid refractory chronic graft versus host disease. So still our first line treatment for chronic graft versus host disease tends to be corticosteroids or prednisone. And approximately half of patients respond to first-line therapy, and the others go on to need or require second, third-line therapies. We do know that there are certain types of chronic graft versus host disease that tend to be harder to treat. I mentioned a couple of them in my slide. So sclerotic symptoms, those that cause sort of more fibrotic impairments, lung graft versus host disease, those are some of the signs and symptoms that tend to be a little bit more difficult to treat. And then finally, just a mention of comorbidity. So we talked a little bit about that pre-transplant comorbidity score. That is a measure of kind of other health conditions that a patient may have. And we have actually done some studies that have looked at comorbidity and its association with chronic graft versus host disease. I believe one study showed that comorbidity doesn't necessarily predict the development of chronic GVHD. However, patients with higher comorbidities with chronic graft versus host disease also have a higher risk of non-relapse mortality or other complications post-transplant. So that there are some risk factors that we know that tend to tell us if chronic GVHD is going to be a little bit more severe or difficult to treat. And that certainly the field is very interested in identifying more biomarkers and things like that can sort of help tell us better how a chronic graft versus host disease case is going to act.
Betty, do you think we have sufficient information yet, as kind of a follow-up question to that? Do we have enough information? So we know about pre-transplant factors that can at least predict who's going to get graft versus host disease. And you mentioned a few of the conditions that might mean that people are less likely to improve, but do you think we have enough information about whether it's the factors of the GVHD, their other complications, or their pre-transplant factors that we could clearly associate with long-term disability? And here I'm thinking of what might be valuable to have sort of systematic risk models that could inform, clinical decision support, either for more aggressive therapy or for predicting disability. And I'm leading somewhere with this question, which I think our panelists know, but we'll come to with another question.
So I think there is a tremendous interest in the field. So I guess the short answer is no.
Yeah.
But I think there's tremendous interest in the field to better identify and sort of preempt chronic graft versus host disease. So the NIH Consensus Conference on Chronic Graft versus Host Disease in 2020 convened a bunch of working groups to sort of see where the field is going. And I think there's a lot of interest in sort of determining clinical and biologic markers that can help us predict who is going to develop chronic graft versus host disease and severe chronic graft versus host disease, so that we can sort of preempt potential treatment, identify patients who really need treatment or who may not need as aggressive treatment.
And so I want to use that to springboard to another question and topic, which Stella, I think this will start best with you, but then I'd like to expand it to Mikhail and Betty, which is that, so we have patients that can develop severe graft versus host disease, and we typically think of them as disabled, but some recover. And I know, particularly in the pediatric environment, there are intensive treatment regimens to try to mediate the devastation of graft versus host disease and or improve on it. And so I wonder, Stella, if you can describe some of these aggressive management strategies that are being done in children, and whether there may be utility in adults as well.
So yeah, that's a great question, Doug. As you know, the field of graft versus host disease treatment has changed radically just in the last 2 to 3 years. The mainstay of treatment has been steroids, and steroids are particularly toxic to a growing child. So our dream is to be able to treat graft versus host disease without steroids. So there are 3 new drugs available to us now: ibrutinib, ruxolitinib, and belumosudil, each of which acts in a slightly different way, has non-overlapping toxicities with steroids, and are currently being used in people who have an unsatisfactory response to steroids. But we see very good responses in children, and I am hoping that we will be able to transition to steroid-free treatment for children, the majority of whom will get better from graft versus host disease, and we'll see less late effects.
But what about non-pharmacologic? So we talked a little bit about aggressive physical therapy, rehabilitation, nutrition type programs. Talk a little bit about that, if you would, please.
Yeah, so there's for people, the appropriate people, there's great value to aggressive physical therapy programs. And we do get creative with the children. We do Pilates, we use video games, we do all kinds of things to try and engage their attention. Children, as it turns out, are very competitive little beasts, and a good game of basketball in the gym can work. So we are aggressive about that, and we do have a gym in our hospital where children can be alone if they're immune compromised, but they can play basketball with their therapist, things of that kind. Nutrition is always extremely important, and you can have too much or too little. We call it the Goldilocks effect. Our children on steroids tend to become quite overweight, and that is problematic. And children with poor absorption or esophageal strictures can become too thin, which is actually easier to ameliorate than the children who are too heavy. So both of those are challenges, and I think the key is to pay attention at the beginning, because once you're 50 pounds behind the 8 ball, it's extraordinarily difficult to fix.
Thanks, Miguel and Betty. Are you aware of similar programs in adult populations? These sort of, whether it's physical and rehabilitation or even vocational training strategies in adults that could mitigate some of the disability that we see?
Yeah, I think as Stella mentioned, obviously now we're in a situation that we have new drugs to treat these patients. But historically, I think the supportive care has been a critical aspect of treating patients with chronic GVHD, and particularly working in an environment where you have a multidisciplinary team that can work with these patients. And I think the physical therapy, the rehabilitation, and also working with the consultants who are critical in managing these patients, the dermatologists, pulmonologists, and so forth, depending on particularly on which organs involved. I think many of the rules that you heard from Stella in pediatrics would also apply to the adult patient population.
Yeah, I agree with that. I think steroids is oftentimes a major issue in terms of patients' ability to their functional status and their quality of life, because it does cause so many adverse effects. I think adults are a little bit more challenging to motivate sometimes. So like maybe not quite as competitive in a basketball game. But it does take a lot of resources to have programs, have sort of systematic programs for adults with, even with physical therapy, and particularly the sort of the social support and the sort of job opportunity type of support. Certainly not every center, our center doesn't necessarily have a dedicated employment. We obviously have a robust social work program, but, not necessarily something that is systematic to help people return to work, and something that is needed, but obviously requires a lot of resources.
I think in that context, one point worth highlighting is the fact that patients often have limited access to physical therapy. They're only allowed so many sessions, based on the insurance. And you often run out of that before they're anywhere close to being done with dealing with their complications. So I think anything we can do to extend the access that patients have to physical therapy is critical. Obviously, as Betty mentioned, motivation is key as well, and the patients also need to do a lot of exercises on their own.
Mm-hmm. Yeah, it strikes me there may be an opportunity as we think about disability, or our patients are applying for disability, whether that might also be an opportunity to engage in, being certain that these patients have access to more aggressive, if you will, rehabilitation and other training, which may increase the likelihood that they won't have long-term disability, although I'm not sure that there's any well-done research yet on that topic. Okay, there's a question from the audience that I think we should talk about here. That question is, what happens if a patient doesn't respond to a transplant, does not experience graft versus host disease? Are there other successful treatment options? Miguel, why don't we start with you, because I'm thinking about one in particular that you obviously mentioned a bit here.
So I think obviously if the patient doesn't respond to the transplant in terms of the underlying disease, for example, and the patient either relapses or progresses, then one of the other options we have today in certain diseases is CAR T cells. But in many patients, the goal would be to try and do a second transplant. Obviously, that's predicated on the fact that the patients are able to go through a second transplant and haven't had complications from the first attempt that make them too sick to proceed. So I think for many of the diseases that we treat, the malignant diseases, not responding to a transplant is really a situation where the options are quite limited, although there is literature on successful second transplants in patients.
Yeah, I think those are in highly selected patients. To the point that Dr. Horowitz made earlier, there's a cumulative burden of treatment, if you will, that begets additional complications. Stella or Betty, do you have anything you want to add to that?
No, our general goal is to try and win the first time because, as you say, the more you persist, the less likely you are to be successful, or the additional cost of that additional therapy.
Miguel, one last question for you that relates to infection and the ongoing and increased risk of infection after transplant, including in a longer term way that we don't always pay as much attention to as we might. There are older recommendations about surveillance, but I wonder whether you might just elaborate for a minute or two on what you think might be represent updated recommendations for surveillance about ongoing infection risk in these patients, especially as we think about how that affects return to work.
I think it's obviously challenging. I mean, the traditional guidelines are that you re-immunize your patients and that then they're okay. And that's obviously assuming they're no longer on immune suppression for graft versus host disease. There are standard guidelines based on timing post-transplant to re-immunize. Mm-hmm. And at our center, traditionally, we've actually followed the parameters of immune reconstitution that I highlighted in our COVID vaccine study to re-immunize based on that timing. But I have a case recently, actually, that I've been seeing in the last few weeks, a patient who's about 4 or 5 years out from transplant, had met all the parameters for immune reconstitution, had successfully been vaccinated, and had demonstrated responses to the standard vaccines, and then was admitted to a local hospital with pneumocystis pneumonia. So clearly illustrating the fact that there is some sort of a gap in the immune system here, that this patient wasn't able to deal with an opportunistic infection, even though, by all testing that we have today, he has reconstituted. So I think there are still areas that we need to further delve into, and maybe doing more detailed analysis of the immune repertoire, such as Leslie Keane and others have done, including us, may be helpful.
I'm chuckling that you mentioned that because I had a similar patient to what you just described with a PJP pneumonia 2.5 weeks ago. Similar situation. And I think we might we focus on graft versus host disease, but I think we may underestimate that ongoing infection risk. I see we're a few minutes past time, and I wonder whether, I think I want to comment on one thing that was also put up in the chat in response to the other question, which we didn't talk about, which is that we focused in this session a bit more on allogeneic transplant than autologous transplants. And I guess it's appropriate to remind folks that for patients who relapsed after receiving an autologous transplant, we sometimes try to rescue them with an allogeneic transplant, hoping for an immunologic effect. But as to Stella's point, our best bet is to win with the first transplant. And I think I'll wrap up and thank all three of us, of the speakers, for your input. Hopefully this is useful to our colleagues at in the Social Security Administration. And I would just say that I think another thing we didn't get time to talk about, but may in the other sessions, is that we've learned a lot in this pandemic. Dr. Perales mentioned a few of the factors that we've learned, but I think we've also learned and can exploit opportunities to follow patients a bit more carefully remotely, because patients aren't always close to the transplant center when they start experiencing their complications, and earlier diagnosis generally leads to better outcomes. And I think we have that opportunity as well. So I'll stop here, thanking all of you for your presentations and the discussion. And I don't know whether I'm supposed to announce the lunch break, but I think we have a lunch break until the bottom of the next hour. So thank you.
Thank you.